Well, it will now be our privilege to hear from Dr. Richard Brown. Dr. Brown is a Madison-based tenured professor. His training includes college and medical school at Brown University, ironically enough, the family practice residency at Overlook Hospital in Summit, New Jersey, and the Robert Wood Johnson Faculty Development Fellowship at the University of Washington. He joined the UW-DFM in 1990, Department of Family Medicine. 1990. Rich's research interests involve the use of innovative technologies and clinical systems to deliver substance abuse prevention and intervention services. He teaches about substance abuse screening and intervention and related topics in several health professional schools and programs at UW-Madison. Until 2006, he saw patients at the Northeast Family Medicine Center. He gave up patient care to serve as clinical director of the Wisconsin Initiative to promote healthy lifestyles, a 5-year, $12.6 million project to enhance delivery of alcohol and drug screening, brief intervention, referral, and treatment services, and other behavioral health prevention services in primary care clinics throughout Wisconsin. I'd also like just to take a moment to thank you, Dr. Brown, for serving as the conference's faculty content reviewer. Without that help, we would not be able to offer continuing education credits, and we're very happy to be able to do so. So please welcome Dr. Richard Brown.
Thank you and good morning. It's a real privilege to speak after Chuck and Shell. They've laid a lot of groundwork, and wow, what a fabulous program, Ron. And so I'll also talk about a particular program that basically can serve as an example of integrating services across various lines to hopefully improve outcomes for individuals in our communities. And that service basically is behavioral screening and intervention, or BSI. And I hope by the end of this talk I'll convince you that this truly would be a win for everybody, patients, families, communities, also providers, payers, and purchasers. I should remind you, I'm a family doctor, so I'm sort of on the other side of that integration barrier coming from the general healthcare system. So that's really where my talk is going to be focused, and we'll talk about how to better bring behavioral and mental health services into general healthcare. Whoops. Okay, so that's a little bit about my background. I'll let you know that when it came to my career choice as a medical student, I was torn between family medicine and psychiatry, and ended up choosing family medicine because I felt I could better address behavioral issues in a mainstream population. So that's really what my career has involved. So although I'm in the general healthcare system, I've really had a strong behavioral health focus the whole way through. I do need to let you know that there's a potential conflict of interest that I have. I've started a company named Wellsys to help general healthcare settings provide behavioral screening and intervention services. However, today I'll be focusing on a program that's available free of charge to general healthcare settings through the UW and through the federal government, so we can actually help healthcare settings around the state start to deliver these services, and this is in no way affiliated with my company. Okay, so here's the bottom line I hope to get across this morning. One is that the behavioral risks and disorders that we've already been talking about are very common, as you know. They frequently generate poor health outcomes and also generate a lot of cost, as we've already heard. How many of you have heard of this triple aim, I'm curious? Triple aim, a few of you. This is the mantra in general healthcare. And basically, federal government has really set some very appropriate and ambitious goals for us. One is that we actually improve the health of our population, because what we've seen, as Chuck illustrated, is that our healthcare system, although it costs way more than other healthcare systems, we tend not to have as healthy a population. So let's improve the health of our population. Let's also generate favorable healthcare experiences among our population, and also let's decrease the cost of care. So I'll demonstrate how BSI would attain that triple aim. I'll talk about how BSI can either prevent chronic illness or improve our treatment of various chronic illnesses. From the hospital standpoint, I'll talk about how we can improve outcomes of patients in hospitals and also prevent those readmissions that we've heard can actually soon will financially penalize hospitals if they have lots of readmissions. Okay? So here's basically what I'll be covering, and first let me talk about the huge challenge we face in general health care, though admittedly most in general health care don't even know about the challenge. So, and I think we would agree that any good healthcare system would be asking itself, well, why are most of our patients dying and what can we do about it? So let's start there. And this is basically why most of us die, and it's been true for several decades now. Okay, so heart disease, cancer, stroke, lung disease, injuries, that's why 2/3 of us die. So then we would want our healthcare systems to ask, I think, well, is there something we can do to prevent all that? And you can see that, gee, tobacco is a major contributor to 4 of these common causes of death. Alcohol use is the most common contributor to injury. It also tends to elevate blood pressure and cholesterol, so it contributes to heart disease and stroke. It also contributes to several cancers. So experts have carried this analysis out to the extreme, and we now know that more than 40% of us die directly because of these theoretically preventable or modifiable behavioral risks. These factors also lead to most chronic disease and most disability. So wow, if we could get a handle on these behavioral risks and disorders, we could dramatically improve the health of our population, eliminate a lot of suffering. So this slide shows how prevalent these behavioral issues are in Wisconsin adults. So about 1 out of 5 of us smoke, 1 out of 4 of us engage in excessive drinking, 8% drug use, 8% depression. More than 3/4 of us don't get adequate fruits and vegetables. About half don't exercise enough. And about 1/4 of us are obese, okay? So wow, if you had to put your finger on who in our population is going to develop a chronic disease or an injury or disability, it's the folks in these categories that are probably going to constitute most of those individuals. And is there something we can do about that? Well, in this talk, I'm going to focus especially on these 4 behavioral issues, and that's because we have the most research to demonstrate that, number 1, we can make a difference, and number 2, we can actually save money at the same time. So really addressing those components of the triple aim. Actually, there's not as much data on drug use for return on investment, but drug use can frequently be addressed while we're addressing alcohol use, and it's actually the same billing code, so that's important practicality in these days. So let's talk a little bit about tobacco. I think you all know what an important risk factor this is for various health problems. It is the #1 leading cause of death in our country. And it's maybe especially important when it affects the next generation with low birth weight, in some cases, childhood disability, lifelong disability, et cetera. So I'm not going to dwell on that so much. I am going to dwell a little bit more on alcohol and drugs because I think people are a little less familiar with some of this information. So this slide is, again, taken from data on Wisconsin adults, and it shows that close to 10% of us have a diagnosable alcohol use disorder in this state, either abuse or dependence. And that's the slice of the pie sticking out there. And you see that little red sliver at the bottom of the slice of that pie, that's the people with alcohol problems who have actually gotten help in the last year. Only 1 in 22 people in our state with an active alcohol problem actually got help in the last year. And some people say, well, gee, maybe they got help the year before, but is that what we say for people with high blood pressure, heart disease, diabetes? Do we say you got help last year, we're not going to help you this year? Okay. And clearly, if people are not getting help, we have every reason to believe they're going to keep drinking as they are and continue to hurt themselves, if not other people in the family and community, okay? Drug use, way less common, though still 2.5% of our population. And again, most individuals with drug use disorders are not getting help in any particular year either. And if they are, it's kind of sad that they tend to get more help through the criminal justice system rather than the healthcare system, okay? So wow, what a tremendous missed opportunity here to identify and help people in need. And of course, drinking and drug use can lead to a whole bunch of terrible health issues and lots of suffering. And often it's not just a health issue, but clear family disruption and a lot of suffering. Those who just are drinking excessively are at higher risk for all of these medical problems, which are quite common. And often we don't even recognize that alcohol is behind that problem. And for some individuals, maybe alcohol didn't cause these problems, But if we don't recognize that somebody's drinking excessively, our treatments are going to be much less effective, and we're going to generate lots of extra costs trying to figure out why the blood pressure is still up, do these other tests, and we're really going to be spinning our wheels because we haven't identified the root of the problem, the drinking. And of course, these alcohol and drug issues spill over into so many other stresses and strains and tragedies in our families and communities. So this slide shows, for example, 44% of falls involve alcohol and drugs. So you can see the percentage of all of these other issues that at least involve alcohol or drugs if they're not directly caused by them. So wow, so many tragedies, so many adverse health impacts, so much suffering, and so much economic cost as well. This is a slide for those who are especially interested in improving hospital care. There's 2 studies in the last couple of years that basically have compared audit scores with surgical complications. The audit is the Alcohol Use Disorders Identification Test. So this shows the score that people get if you, when they were asked a few questions from the audit. If they got a 0, it means they don't drink at all. If they got a 12, it means they drink a lot every day. And you can see as the score goes up past 5 or so, we see more patients who are just having surgery for a variety of causes. They will suffer more complications from surgery. And that means worse health outcomes, higher healthcare costs. And hospitals these days are pressed to provide more and more data on the quality of their care. So this is going to be some incentive for hospitals to pay closer attention to their patients' drinking if they want to improve their surgical outcomes. Okay. We heard a couple of times about the importance that hospitals realize in preventing readmissions, and this is one study that shows that, gee, if patients have drug problems, they're more likely to be readmitted to the hospital within 30 days or more likely to come to the ER. And there are similar studies that show that tobacco use, alcohol, excessive drinking, and depression are risk factors as well. So if hospitals are going to get a handle on those readmissions, they're going to have to address these issues. And now here's the kicker. Well, who are the people in our population who are drinking excessively or using drugs? They often don't fit the stereotypes that many of us have. So most of these people are employed, and most of these people are white, non-Hispanic, and not in poverty. Okay? So this is not just a them problem, this is an all of us problem. How can we get a better handle and recognize these issues and intervene? So now I want to focus on depression. You can see about 10% of patients coming to a regular family doctor are depressed at any given moment. And unfortunately, we tend to miss the diagnosis in 1/3 to 1/2 of those patients. What a terrible missed opportunity because we know that treatment for depression is so effective. And I want to emphasize one fact on the bottom that actually, we're certainly well aware that, as Shell talked about, we want to prevent suicides, but more depressed people die because they don't take good care of themselves when they have other chronic illnesses. More people die of that than suicide, okay? Okay, and now I want to give you a little information about the cost impacts here. So basically, this is across the nation. This is how many billions of dollars that get spent in the healthcare system for these issues, and most of these dollars are not spent addressing the root of the issue. More than 90% of these dollars are spent addressing the problems that get caused by these issues. So the heart disease, stroke, and the cancer, and the injuries, and the disability, and so forth. Add to that dollars that we lose from lost productivity, which mainly fall to employers. And employers, of course, are paying for a lot of healthcare as well. And then there's some other costs, justice costs, social services costs, et cetera. So across the country, these 4 issues alone are costing us over $650 billion. Wow. And again, all theoretically preventable and treatable. Okay? Now let's take a bit of look at the costs in the private sector for employers. Just a couple of pieces of information. For every employee who smokes, employers lose out on over $3,700 a year. And again, most of that's lost productivity, but a lot of it is in healthcare costs as well. If employees are engaging in binge drinking or risky drinking, double the healthcare costs, triple the workplace injuries, employers are on the hook for that. And depression we see similar to tobacco, costing employers more than $3,000 a year, mainly in lost productivity. Okay? So these are huge issues that are not just affecting healthcare, not just mental health, they're dramatically spilling over into the business community. And now a little more information on costs in the public sector. We heard earlier how costly patients are if they fall in that dual eligible category. Patients who have Medicare because they're disabled and Medicaid because they're low income. So this is more data from the study that Chuck mentioned earlier, this Faces of Medicaid data. It's on the web. And basically, this study looked across the nation at those dual eligible patients who have these chronic diseases, and they asked the question, well, how many of these people with each of these diseases actually has been diagnosed with some mental health or alcohol or drug problem? And what they found was only a quarter to a third of these individuals have no mental health or alcohol or drug problem. About half of them have a mental health disorder, another several percent have an alcohol or drug use disorder, and another 10 or 20% have both. So, wow, if we're going to improve care for these important chronic diseases, very prevalent, we can't only look at the medical issue. We have to consider how the mental health and alcohol and drug issues are interacting with these behaviors, with these chronic illnesses, interfering with self-care and causing other problems as well. So this clearly has tremendous costs. So this next slide shows how many hospitalizations does the average patient with these problems have per year. And you can see across the board for people without mental health or alcohol or drug problems, less than 1 hospitalization per year. That's pretty good. Add a mental health problem, more hospitalizations. Add an alcohol or drug problem, even more hospitalizations. And for folks who have both, way more hospitalizations. And most of these are general hospitalizations. They're not psych hospitalizations. And so when people have a mental health or alcohol or drug problem in addition to their chronic disease, we see 3 to 6 times the number of hospitalizations. Huge costs to our healthcare system. And people have looked at total costs of care. So for example, the average person with hypertension without a mental health or alcohol or drug problem costs $16,000 of care per year. You can see the cost for the other problems. If there's a mental health diagnosis, quite a bit higher. Alcohol or drug, similar. And if people have both, way higher. Okay? So, obviously these behavioral issues are so common in healthcare. So we see 2 to 5 times the cost here. So we are literally flooded in healthcare with patients who have these mental health and alcohol or drug issues. And we don't even recognize it, okay? And wow, if we could systematically get a handle on this, we could make a huge difference for patients and also dramatically reduce costs, okay? So at this point in the talk that I typically give on this, most people in the audience are starting to get depressed. It's pretty overwhelming. And it's really a question, do we choose to recognize it and deal with it? Or do we choose to just keep the blinders on and keep on plodding along as we are? So the good news now to help maybe lift your depression is that behavioral screening and intervention could make a huge difference. So here's how it works. When you come to general healthcare setting once a year, you're asked to respond to some quick screening questions, maybe 1 or 2 questions for each of those behavioral issues. If you're in the low risk category for the screening questions, we reassure you you're fine. We reinforce those good healthy behaviors, and then we're done. Patients who have a positive screen, we ask them additional questions to see how much risk or how much of a problem they have. Some of those folks may turn out to be low risk. Maybe their screening question was a false positive. So we reassure them. That handout comes later. Okay, thanks. And those who assess as having intermediate risk, we do interventions right there in the general healthcare system. We don't need to refer people at all. So those are the low-hanging fruit who give us really the best bang for the buck with these the services. We certainly will, of course, uncover people with alcoholism, addiction, depression, and those folks we certainly want to refer. And as we've heard earlier this morning and last night, it can be especially helpful if people can access those services more in general healthcare settings rather than going across town or even to the next county. So more people will actually get that help. And then, of course, we want to follow up and see, are the services people are getting, whether it's specialty services or services within general healthcare, are they making a difference, or do we need to modify the treatment plan, okay? So that's basically all BSI is. And basically, as we heard from Shell when he talked about Henry Ford's suicide program, This is not rocket science. This was looking back and seeing, what's already been done and how can we systematically deliver these services so we make a difference for the largest number of patients possible. So now I'm going to summarize some of that old research on how effective these services could be if we could administer them to all patients. So again, tobacco use, #1 cause of death in our population. The latest federal guideline on treating tobacco use combine a whole bunch of studies together, and they realized that when smokers go to clinics where there's no screening going on, about 3% of them end up quitting for a year soon after one of those visits. So these were people who were going to quit anyway. They didn't get help in healthcare, but that's okay. Actually, most people who quit don't need help, and they just need firm commitment, and they can do well. But in healthcare settings that do screen patients and presumably offer some help, we can double the quit rate. But look what happens in healthcare settings where we not only screen, but we make sure to offer optimal intervention services to patients. Look at that quit rate. Wow. And again, this is the #1 thing we can do to prevent death in our country. So what is optimal intervention? What would it take? Well, the research tells us about that as well. Patients do best if they get a combination of medication and counseling. So there's a little suggestion for integration. Also, patients do best if they get individual counseling. And so often we think we're doing best by our patients just by referring them to a class or a group or a quit line, but if we actually gave one-on-one counseling to patients, we would actually get higher quit rates, and if they could take advantage of multiple modalities, they do even best. Patients do best if they get somewhere between a half hour and 5 hours of total one-on-one counseling. And when I talk to my primary care colleagues about this, we'll say, well, that's ridiculous. We never give that. Say, well, that's what the research shows would be most effective. And it shouldn't be surprising to us. I've sort of informally specialized in alcohol and drugs and have treated a lot of patients over the years. And I've seen so many patients who can get into recovery for alcohol, marijuana, cocaine, heroin, even methamphetamine, but they still can't lick their tobacco use. Nicotine tends to be the most addictive drug for many individuals. It's not surprising it should take several counseling sessions and ongoing support to give people the best outcomes. It's good news that physicians don't have to deliver the counseling. Non-physicians can get just as high quit rates. And it's actually best if clinicians collaborate and maybe a physician can handle the medication issues and reinforce the counseling that a non-physician delivers. It's probably a good cost-effective approach there, okay? So we know how we could help many more people quit smoking and avoid the #1 leading cause of death in our country, but virtually nobody is getting those services. Very sad. Here's another huge missed opportunity, alcohol interventions. And I'll tell you in a few minutes what these are, but first let me tell you about the success. And notice on the bottom, this is data that was pulled together by the National Business Group on Health. This is a national organization of employers that are advising employers around the country, make sure your health plan reimburses for these services, make sure your employees get these services in general health care, because you will save money and improve the health of your workforce. So they looked at over 50 randomized controlled trials in the medical literature, found that brief interventions decreased total drinking only by about 10%, not very much. They decreased the number of binges by about 20%. And what do I mean by a binge? Well, actually, the way it's defined, it's really more of an episode of risky drinking. And first of all, we have to make sure we're talking to patients and using a standard vocabulary. And so we want to talk in terms of standard drinks. And a lot of people in Wisconsin are surprised that 12 ounces of beer contains the same amount of alcohol as 1.5 ounces of 80 proof liquor, vodka and whiskey. Same as 5 ounces of wine. It's all the exact same amount of alcohol. And in terms of those standard drinks, hundreds of studies have shown us when men drink more than 4 drinks on an occasion, when women have more than 3 drinks on an occasion, we start to see risk for negative health and social consequences. And I know in Wisconsin, when I give this talk, most people are surprised how low these numbers are. I've given this kind of talk in many other states, and in those states, they're surprised how high the numbers are, okay? And we actually lead the nation in binge drinking and a number of other measures of excessive drinking, unfortunately, okay? So that's what we mean by a binge. So we reduce the number of binges by 20%. We also reduce the severity of binges. So if somebody used to have a 12-pack during a Packer game and now they just have a 6-pack, it's still a binge, but clearly there's going to be fewer health and social consequences. So when we deliver these interventions, look what happens across our patient populations. Decrease injuries by 1/3. Decrease emergency department visits by 20%. Decrease hospital admissions by more than 1/3. And look at this, decrease arrests and car crashes by about half. And I always get tingles in my body when I pull together these facts with a reminder that 20% of adults in this state are binge drinkers. And most of them, if they binge drink once a month, they're drinking at least 4 times a month. If we could multiply these benefits over 25% of adults in all of our communities, wow. Our families would be stronger, our communities would be safer, healthcare would cost much less, workplaces would be more productive, and in fact, there's 3 studies that actually show us we could save money. So one study actually performed in clinics in southeastern and south central Wisconsin showed that for every patient who got these brief interventions in primary care, we saved close to $1,000 over the next year. And most of the savings were because of fewer emergency department visits and fewer hospitalizations. Another study was done by a trauma surgeon for patients who came to emergency departments and trauma centers with alcohol-related injuries. And when patients got brief interventions, we decreased the rate of alcohol-related re-injury almost in half over the next year. And both of these studies showed savings of about $4 for every dollar we spent within that year. How often do we hear from people, well, gee, if it's going to cost me more this year, I can't do it, even though it's going to save me money next year. Well, here you can actually get the savings in the same budget year. Another study in Washington state emergency rooms looked especially at those dual eligible patients, those patients with Medicare and Medicaid who are very costly to our system. They found when patients got these services, we saved over $4,000 per patient over the next year. Huge savings we can get in the healthcare system by delivering these services, okay? So you may wonder, well, what's going on here? I thought people needed to go to treatment. What are these brief interventions all about? So to explain that, I need to get across this important notion that there's a continuum of substance use. So often we end up focusing especially on patients with alcoholism, but in reality there's a continuum of drinking from abstinence to heavy use, and the more somebody drinks, the higher the risk and the more numerous and severe problems they'll encounter. And then, yeah, at the end of the spectrum, there's a continuum of symptoms of alcohol dependence, the preoccupation, the difficulty for people, they just can't stop thinking about drinking or drug use. They may have urges and cravings, and all of that can lead to difficulty controlling their drinking. So try as people may try to quit or cut down, they just can't consistently do it. And we now know that this truly comes from a disease of the brain. So this is a PET scan to show the function of the pleasure-reward system of our brains. So this is a system that nature apparently gave us in all animals, makes us feel good after we've had a nice meal, so it rewards eating, keep the species going, keep the individual surviving. It makes us feel good when we have sex, so it rewards sexual behavior, it keeps the species going. So that's the function of this pleasure-reward system. And the PET scan here shows a normal pleasure-reward system, somebody who's not addicted. The red shows the nerve cells that are functioning most. So this is the amount of nervous conduction we need to see in a pleasure-reward system to tell the rest of the brain, hey, this may not be the best talk I've ever been to, but soon I'm going to have lunch, and it's a nice day outside, okay? So life is okay. So here is the pleasure-reward center of somebody who's addicted, but they haven't had their substance for the last month. And look, the red is almost gone. So this is a pleasure-reward system that is screaming to the rest of the brain, you feel miserable, you feel abnormal, you feel that something is just not right, you feel very uncomfortable. And the only way you can resolve that is to go back and drink or use some more, okay? So that's where these terrible urges and cravings come from. The good news is we kept this individual clean and sober for 2 years, and look, the red is coming back. And the other differences are just because the PET scan was taken at a slightly different level of the brain, okay? So this shows this is clearly a brain disease. This is really what addiction is. This is what leads to that loss of control. It has a well-known biological explanation now. So those are folks who consist of about 6 to 7% of our population, and those are people we know from many, many studies. They clearly do best if they get treatment. You know, treatment's not perfect, but it's very clear people who get treatment do better than people who don't get treatment as a group. And the goal of treatment is to get people to abstain, because even a little bit of drinking or drug use can trigger more urges and cravings and lead to more loss of control. So where brief interventions work are instead people who are not dependent, but they're at high risk or they're already suffering some alcohol or drug-related problems in their lives. And notice these people in the middle category here outnumber the dependent people by about 3 to 1. And in fact, because of that, they actually cause more total harm in our communities and workplaces. So these are the low-hanging fruit. They don't need to go to treatment. They are in full control of their drinking and drug use. At least their pleasure reward system is not interfering with that control. So the goal of brief interventions here, we don't have to strive for abstinence. We strive to get people to drink in a healthier and safer way. So we strive to get people to cut down as much as they will. And that's what leads to all that success with the reductions in emergency room visits, hospitalizations, car crashes, arrests, etc. And we have to remember, we cannot tell who most people are just by looking at them. We can't tell which category people fall into. So it's been recommended now for 1995, wow, 17 years, that all healthcare settings should be screening people for their alcohol use and delivering these interventions. 17 years. And there's 7 studies that show that these services are effective for various drugs as well. Okay? So that's all the wonderful things we can be doing about alcohol and drugs. You've already heard Chuck talk a bit about collaborative care for depression, using that validated assessment tool, the PHQ-9, educating patients, coordinating care, making sure referrals happen, facilitating communication among the treatment team, monitoring care by re-administering that PHQ-9 and adjusting treatment as necessary, promoting adherence to treatment plan, not just at face-to-face visits, but calling patients at home regularly, and then a psychiatrist to review, especially when patients are not getting well as quick as we might. We can also add into collaborative care behavioral activation interventions. So this basically involves promoting behaviors that most of our grandmas assumed would be helpful for depression. Getting people exercising, sleep hygiene, having fun in their lives, socializing, eating healthier, and for patients whose depression is causing anxiety symptoms, teaching them some relaxation exercises. So there's many studies that show that this is nearly as effective as full-fledged cognitive behavioral therapy. And for minor depression, it can prevent many patients from progressing to major depression, okay? So when we do this, as Chuck said, there's lots of studies that show that this kind of care is much better than the typical care. It needs to be combined with the typical care that patients get in primary care, and we save money again. So we not only reduce the suffering from depression, but for the $900 it costs in that first year to deliver collaborative care, we get to save over $5,000 over 4 years, okay? So that's a summary of the research that convinced the U.S. Preventive Services Task Force, the leading prevention gurus in our country, to recommend that all patients get screened for these issues at least once a year. And we deliver these interventions systematically across our patient population. And I want to tell you about this other group. This National Commission on Prevention Priorities was asked to come along and answer the question, well, gee, if we can only get some preventive services to some of our patients, which actually give us the best bang for the buck? Which actually reduce the most deaths, injury, and disease, and which would actually save us the most money. And if you haven't looked ahead on your slides, anybody want to guess what the #1 service would be? It's nothing I've mentioned so far, but it's a great illustration of this bang for the buck concept. Any guesses out there? Okay. Well, #1 is making sure patients at risk for heart attack and stroke take an aspirin a day. It's really effective. It prevents lots of heart attacks and strokes and deaths, and it's really cheap, and most people can remember to take that aspirin once a day, okay? #2, making sure kids get their shots, and actually Wisconsin leads the nation in the proportion of kids who are getting shots according to schedule. We're all very proud of that. #3 and 4, tobacco and alcohol screening and intervention. So these services, according to this very objective group of scientists, are more effective and would save more money than all these other really great preventive services. Of course you're going to get your blood pressure checked, cholesterol checked. Of course you're going to get cancer screening. Of course you're going to get shots every so often as an adult. These are great services. But even more effective, even more cost-effective would be screening and intervening systematically for tobacco and alcohol. Depression came down lower on the list, number 18 out of 25, still better than a lot of preventive services we take for granted. And this commission focused just on healthcare cost savings. If they had focused on cost savings in the workplace, depression would have been ranked up around 9th or 10th along with mammograms and pap smears, okay? So clearly we ought to be systematically delivering these screening and intervention services. Employers would clearly benefit. So we'd increase those quit rates, we'd reduce healthcare utilization, and reduce a lot of costs relating to depression. Okay. So how are we doing? Most clinics are not delivering these services. So how can we integrate these services into healthcare? Typically, patients walk into one of our participating clinics. We've done this in over 30 clinics around the state. The receptionist asks them to fill out a questionnaire. The medical assistant who checks vital signs reviews the questionnaire. And a health educator who's there full-time. We train that health educator. We support them in delivering good services. They handle all the patients who screen positive. And it's really key to add that health educator to the system because current doctors and nurses just don't have time to address the 20% of patients who smoke, the 25% who drink too much, the 8% who use drugs, the 10% who are depressed. They need help with all of that. In the hospital emergency department, it's even easier. We send a health educator around. Patients are a bit more of a captive audience. They introduce themselves and deliver the services. So here's how we've done, helping dozens of settings around Wisconsin deliver these services. We've screened over 115,000 patients. We've gotten high patient satisfaction. Patients are pleased to talk about this with people. They do give accurate responses because our health educators are trained in motivational interviewing and establishing good rapport with patients. We actually decreased binge drinking by 20%, the same as the National Business Group on Health found was true in other studies. We decreased regular marijuana use by about a half. And over 8 to 12 weeks, we reduced depressive symptoms by more than half, okay? So this is what you can do just by adding a health educator to the team who is well versed in delivering these services and following protocols. So this is clearly happening, or there's lots of incentives for this to happen. You've heard about patient-centered medical homes. Once a clinic adopts this team approach to better coordinated care, systematic prevention, and so forth, they actually get reimbursed at a higher rate from third-party payers. So there's incentive to build BSI in now. Perhaps you've heard of accountable care organizations. This is just starting up now. We have 2 ACOs in Wisconsin, one in the Fox Valley, one in Milwaukee. I'm sure there's going to be more. And basically, healthcare organizations get to keep more than half of the healthcare dollars they help save. And so if BSI saves all this money, there's going to be strong incentive for these ACOs to make sure patients are getting these services. The Joint Commission, the #1 organization that accredits hospitals around the country, now has optional quality measures for tobacco and alcohol screening and intervention, likely to become required so that every patient, maybe in the next couple of years, who gets admitted to the hospital is going to have to get these services. Also, we've talked about the importance that hospitals realize now in preventing readmissions. These services would help there as well. Hospitals would get paid more. And we've heard about how employers are just desperate to, you like those slides? It's amazing what you can find on the web these days, huh? So this would clearly please employers if the healthcare system were to do this. This would really help them in some important ways. And think of all the positive spillover to communities if the healthcare system steps up and delivers these services. These are the national groups that support it. The one on the right is the Drug Czar. The Business Healthcare Group is in Milwaukee. They cover 300,000 individuals with healthcare, and they're actually putting in their 2013 contracts with their 5 health provider organizations, you've got to start providing these services or we're going to send our patients elsewhere. And they tend to be at the cutting edge, so I suspect this is going to happen elsewhere soon around the state. As a matter of fact, one thing I hope you will do is to get this kind of momentum happening here up north. And Wisconsin Manufacturers and Commerce is behind this. They're recommending this to their employer members, and the Medical Society and the umbrella organization for FQHCs is behind this as well. Now you may be wondering who's going to pay for this. We've documented that all of these health plans around the state have been paying for this, including Medicaid, Okay, and here's the website for the Medicaid reimbursement policy. So I won't bore you with the details here, just suffice it to say that actually clinics can actually do this and more than break even. So a clinic that's just seeing Medicaid patients can break even just delivering these services 2 hours a day, leaving that health educator 6 hours a day to either deliver more services, make a profit, or deliver unreimbursed services. Unfortunately, the depression services are unreimbursed so far. And here's a little bit of a spreadsheet for commercial clinics that show that if they're serving Medicaid and commercial patients, they can generate revenue up to $150,000 a year. The average health educator makes about $60,000 with salary and benefits, so there's clearly a lot of room for profit here. And then this is built into PPACA, the healthcare reform bill. We're not sure if that's going to survive, but even if it doesn't, there's lots of other federal momentum in this direction. Surgeon General is pushing this, and so this is going to continue to move forward even without healthcare reform. So I want to end with telling you about how this can start to happen in your community if you like. We have funding from the AHRQ, the Agency for Healthcare Research and Quality. We're working with 3 other states. This funding allows us to go out and work with clinics, train health educators, support health educators. Yeah, if you could give out those handouts now, please. This is a handout that describes the program. And so now the program does not pay for the salaries of the health educators, but it does pay for lots of, in fact, most of the startup costs. So clinics can start to deliver these services and more than break even doing so, okay? So these are some of the clinics who are involved with this program. There are several other clinics that were involved with the previous grant who, despite the end of grant funding, are still delivering services. They're paying health educators. They're more than breaking even. So this is not only a reality in terms of being able to help patients and reduce suffering and save money, but it's a reality in terms of settings being able to deliver these services in a financially sustainable way. Other locations here left over from our last grant that are still delivering services. The closest one is the FQHC in Wautoma, Family Health La Clinica. There's clinics in Milwaukee, Madison, La Crosse, several other locations. So I won't go through the details of the program, so I just want to emphasize the bottom line. These behavioral risks and disorders are very common. We know that they contribute to a lot of poor health outcomes and generate a lot of costs. These services would help improve health, decrease costs. Patients are happy to receive them. We would prevent chronic illness. We would better treat lots of other chronic illnesses. We would improve lots of hospital outcomes. There's lots of other reasons that healthcare settings are having increasing incentive to deliver these services. I think an important bottom line is this is clearly the right thing to do for patients. They would benefit, and my staff and I can help clinics deliver this program. This is our saying, time to ask. Okay? It's time that we pay attention to these issues in a systematic way, and when you add a health educator to your team, there is time to ask patients about this because there's somebody there who can respond. So these are ways I hope you can help. If you work in a healthcare setting, I hope you can help push your healthcare setting to consider this. I'm glad to come and give talks up here whenever folks are interested, meet with healthcare settings. If you work for a payer or have some influence there, I hope you can encourage them to reimburse if they're not already doing so, though in this state most are. And I think most of you fall into that bottom category as a citizen, and I think a couple of government officials here. Governments would especially stand to benefit. Not only would you decrease your healthcare costs and improve productivity and decrease workplace injuries for your employees, but you would also benefit from the reduced demand for law enforcement, justice, social services settings in your jurisdiction as well. So I hope you'll all decide that you want to advocate for this and suggest to your healthcare settings, hey, really give us some thought. Again, I'm glad to come back up to Wausau or go anywhere around the state and educate people more about this opportunity. So thank you for your attention and for holding out before lunch.